Thank you, Dr. Ayman. Our next abstract is outcome of abdominal aortic aneurysm repair among patients with rheumatoid arthritis. It will be presented by Dr. Ibrahim Al-Maghlouth. He's Assistant Professor, Rheumatology Unit, Department of Medicine at King Saud University. He's the Assistant Director of College of Medicine Research Center and Director of Research Registries Database, King Saud University Medical City. He's a principal investigator of the National Prospective Cohort of SLE in Saudi Arabia. So please, Dr. Ibrahim.
يعطيك العافية دكتور. بصراحة هذه مقدمة طويلة يعني، وأنا ما أتوقع أني أستحق كل هذه المقدمة يعني، إن شاء الله في وجود القامات يعني، فيعطيكم العافية. و I'm very delighted صراحة to present in front of my teachers and mentors. I'm sometimes challenged by the mic, فيعني yes, perfect. So the talk is really about the outcomes of abdominal aortic aneurysm in patients with rheumatoid arthritis. I have no relevant disclosure for this talk, but we can talk about other disclosures later. The story starts from the facts that patients with rheumatoid arthritis are at increased risk of cardiovascular events. Now, we know the famous studies on risk of mortality in patients with rheumatoid arthritis. For example, in a population-based study that was recently done in Ontario, Canada, we noticed that patients with rheumatoid arthritis in the purple color have increased excess mortality. And when we look at the cause-specific mortality, such as the study by Solomon, which is a very famous study on the cause-specific mortality in rheumatoid arthritis, we noticed that the patient with rheumatoid arthritis at an increased risk of mortality. And sorry, again, I'm technically challenged sometimes. They are at increased risk of mortality specifically related to cardiovascular event, whether this is a coronary artery disease or stroke or other vascular events such as abdominal aortic aneurysm. You can see here in the adjusted model by Solomon that the risk is increased about two-fold increased compared to the general population, even after you adjust for comorbidities and other known risk factors for cardiovascular events. The question is, why patients with rheumatoid arthritis have an increased risk of cardiovascular disease? We have three major mechanisms through which rheumatoid arthritis patients tend to have increased risk of cardiovascular disease. The first one is the accelerated atherosclerosis. Most of us are familiar with the fact that patients with rheumatoid arthritis have about two-fold increased risk of cardiovascular events when you put them compared to the general population. And usually, when you look at their atherosclerotic burden, you see it more and at an earlier stage. Now, in addition to that, studies showed that there are cystic changes that happen in the wall of the arteries in patients with rheumatoid arthritis compared to the general population. And the third mechanism is thought to be related to inflammation within the vessels, so i.e. vasculitis, which seems to correlate with the disease activity. Now, all these three mechanisms can increase the risk of vessels damage and eventually the formation of aneurysm and subsequently complications such as rupture aneurysm, which carries by itself increased risk of mortality. The challenging part that we face was, in the past, we had no studies addressing the risk of surgical intervention in patients with rheumatoid arthritis in terms of vascular intervention, either open vascular repair or endovascular repair. And that's an important question for us as a rheumatologist, because the vascular surgeon will refer a patient with rheumatoid arthritis who has an aneurysm to you asking for your permission to go for surgery. Unfortunately, there is no guidance and no literature with this regard. So do patients with rheumatoid arthritis have increased complication after vascular intervention? Question number one. Question number two, does this risk varies according to the type of intervention, i.e. open repair versus endovascular repair? And third question is, what are the factors that can contribute to this? In order to address this in a best possible way, knowing that these events are not common events, we conducted a population-based study. This population-based study took place in Ontario, Canada, on all Canadian who have been registered in the healthcare system. So it's a population-based study using health administrative databases. Now, what does that mean? That we use the the ICD codes for rheumatoid arthritis and other codes to form a cohort of patients who based on this cohort, fits the definition of rheumatoid arthritis. Now, your question will be, how do you make sure that those patients are actually rheumatoid and not misclassified based on someone entering the wrong data in the coding or the billing system? And that's how this is usually addressed through validation process, and this cohort was already validated in previous papers with a specificity of 100%. So we are 100% sure that those patients are rheumatoid based on chart reviews compared to the cohort creation. Now, in addition, the second question is, people who tend to have, a patient with rheumatoid arthritis who tend to have aneurysm formation may systemically be different than those who did not develop aneurysm formation. And our study design is a cohort study, so we will compare those who have aneurysm versus those who did not have aneurysm in terms of overall feature. And then those who go for surgical intervention, we compare them to the general population after we adjust for common confounders, so diabetes, hypertension, and other risk factors. And in order to address this imbalance, we used propensity score methods that many of you know that I love it so much, in order to improve the balance between both study groups. Now, just to make the story short, the primary outcome of the study was all-cause mortality, and the secondary outcome were the MACE, so major adverse cardiovascular events, in addition to other outcomes, including surgical outcomes, recurrence, repair, the need of repair, and things along this line. In order to address the potential issues related to the study design, we did a couple of sensitivity analysis. We'll not go into the statistical point, but I'm more than happy to address that later. Now, let's go to the results. As you can see, this is a very busy slide that highlights the findings of the table 1, the features of the cohort. So you can see that the average, that the study population majority are elderly, and that's expected in patients with abdominal aortic aneurysm. You can see that the patient RA whom we compared to non-RA for the outcome of interest, which is the outcome of surgical intervention, they are systematically different based on the standardized difference. So if you look at the standardized difference, when this number is more than 0.1, we consider this a significant difference, i.e. those groups are not alike. You're comparing apple to orange. And you can see that after we apply the correction method, which is the propensity score match here, you can see the standardized difference is improved significantly, and almost all variables are been back to appropriate balance, i.e. both groups are similar in everything except the fact that they have rheumatoid arthritis versus not. Now, what about the outcomes? So the outcomes of this study is very interesting, and I want to highlight it in details. So the first part, in the unadjusted model. So when we compare patients with rheumatoid arthritis who have abdominal aortic aneurysm going for surgical repair, irrespective of the surgical repair, to general population, to the population who are similar in more or less, we see that patients with rheumatoid arthritis have excess risk of all-cause mortality and major cardiovascular events. However, this difference is mitigated, or this difference does not exist when we account for other factors and when we adjust the model, i.e. when we apply the propensity score, both groups looks the same in terms of outcomes. What does that mean? That means simply that patient with rheumatoid arthritis patients with rheumatoid arthritis do have increased risk. This risk unlikely to be related to rheumatoid by itself, but rather explained by two major factors: their comorbidities, measured by comorbidity index, and by the medication, particularly steroid. And this is very important for us as a rheumatologist. We'll get to that in a second. This is the Kaplan-Meier curve, and you can see that both groups in an unadjusted fashion, they are different. So there's a difference between the blue and the red one, blue representing rheumatoid arthritis patients, so they have increased risk. However, the general population, this risk is mitigated, as you can see here, after we adjust for comorbidities and steroid. Now, why this is the same thing we found with essentially the same findings were similar irrespective of the surgical intervention. So if you do open repair versus endovascular repair, they are all the same. And also for all secondary analyses, sensitivity analysis and whatnot, they are the same. Now, I think because of the time, I will not go into the other sensitivity analysis, but the message is loud and clear. Patients with rheumatoid arthritis do tend to have increased risk of mortality, but this is likely to be accounted for the comorbidities and steroid. And why this is important for us as a rheumatologist, because in the clinical practice, when you have someone with rheumatoid arthritis coming for surgical intervention, and the finding seems in some data that I did not show, seems to be it seems to exist irrespective of the type of surgery, even if they are going for different kind of surgeries. Steroids tend to increase the risk of mortality as well as major cardiovascular event. So when you have someone on steroid going for surgery, the first rule that you should do is try to reduce the level, the steroid, or taper it down, especially around the surgery time. And this is very important in your clinical practice, even when they are on small doses of steroid. Try your best to reduce it. Of course, address the steroid, address the fact that they are on steroid for a long time, so stress dosing, but try to minimize their dose of steroid before they go for surgery, because this is for sure going to increase the risk of complication after the procedure. And with that, I conclude. Thanks to my co-investigator, Dr. Salata, and Dr. Professor Mohammed Al-Umran. This was funded by a joint fund between King Saud University and University of Toronto. Thank you so much for your time.